Let's talk about medication reconciliation. By now, you've probably heard the message that we need a standardized process for reviewing medications and allergies. There's enough literature out there to suggest that medication discrepancies are common in healthcare and, if unchecked, can result in adverse outcomes. The same literature states that medication reconciliation can identify data discrepancies and reduce the probability of error. And yet, few healthcare systems have reliable processes in place to reconcile medications. We know it's important, so why isn't it a priority? Some people would argue that the average medication history takes too much time. There's the prep, then there's the interview, then there's the time spent actually doing something with all the information. When we look at that on balance, with the fact that the probability of a bad outcome caused by a discrepancy is actually really low, we may ask ourselves, is it worthwhile? When a patient's standing there asking for help, the priority's clear. It is our responsibility to manage a disease, address a symptom, request a consult, or something else, and medication reconciliation becomes the second or third priority. While it may not seem worthwhile on an individual level, let's look at how it could affect our patient population in general. A study by Dr. Kenneth Bookvar at the Bronx VA shows that any given discrepancy has a positive predictive probability of 0.048 for causing an adverse drug event. About half of those discrepancies are unintentional, and only an estimated 13% of those unintentional discrepancies result in significant harm. It's a small number, but there could be multiple discrepancies in any given clinical encounter. Some studies say between 2 and 4. Depending on how ill the patient may be, we've seen them as high as 8 or 12. For the sake of argument, let's take the conservative average and say 2 discrepancies at a positive predictive value of 0.003. The probability of an adverse drug event per clinical encounter is still close to 0. It means a lot of discrepancies will go unnoticed. But there's a very small probability that some of those discrepancies will limit a patient's quality of life. So, how many clinical encounters are there in an outpatient setting per year? Nationwide, tertiary care facilities like mine complete about 500,000 clinical encounters annually. When we factor that in, suddenly we're at 3,000 very real events. Taking the inpatient setting into account, that number jumps to nearly 3,500. We're talking morbidity, mortality, or a significant decrease in the quality of life. That's a lot. 3,500 events per year, per institution. So I guess the real question is, how bad must the situation get before we start investing real time and resources into a reconciliation strategy? Let's look outside of healthcare for a moment. Would this consistently high number of accidents or deaths be acceptable in the aviation or automobile industries? Think about the amount of time spent on safety checks and equipment, the meticulous steps taken to improve safety in travel. One day I hope to see the same amount of time, resources, and thought invested into standardizing and improving our medication processes. Because if we were to do so, we could avoid 3,500 bad outcomes per hospital per year. When you scale that up, is it worthwhile? Absolutely. I guess that just leaves us with one last question. Where is medication reconciliation in your list of priorities? If you ask clinicians whether medication reconciliation should be a priority, they'd probably hesitate. But thinking about it in terms of our entire healthcare system, should we make it a priority? Yes, without a doubt. And it has to start at the clinic encounter with the medication interview. At the end of the day, patients are like passengers traveling through our points of care, and medication reconciliation is like our cross-check to ensure they do so safely, again and again and again.